So welcome everyone to today's webinar on with Continence New Zealand on mesh. So I would like to welcome Dr John Short, who's joining us from Christchurch today to talk about this subject. Thank John for giving up his time to do this wee talk with me today for Continence New Zealand. John, for those who haven't heard of him before, specialises in incontinence and prolapse repair and is a gynaecologist based in Christchurch, New Zealand. He's currently the chairman of the Urogynecology Society of New Zealand and Australia, so it's quite an esteemed position. So thank you very much for joining us today to talk about mesh.
You're very welcome. It's nice to be involved.
So I think we'll kick off with a very broad question, but a very good question, which is, what is mesh?
So mesh is a material that we use in some surgeries. It's usually made in this context from what's called polypropylene. And it's got the name mesh because of a characteristic pattern, very similar to what you can see on the wardrobe behind me in the lattice work. And the way the fibres weave together to form what's called the mesh. The specific surgeries we use it for in this context would be vaginal prolapse and urinary incontinence.
Okay.
And the idea was that it was an alternative to either using the patient's own tissue or repairing the patient's own tissue. And hopefully provide a more durable result. But as we may hear, that hasn't necessarily been without its own problems.
Okay, so in terms of where the mesh goes, so for both you and I are quite familiar, given we operate in these areas, of where it's placed, but if you had a patient that was coming to see you and they said, well, where is this mesh being placed? Where is this in my body? Where are we placing this mesh? How would you describe that?
So how I would describe this is for urinary incontinence, we're aiming to place a thin strip of mesh underneath the urethra. So for a patient, that's going to be explained as the tube that transports the urine from the bladder to the outside. And we're aiming for the midpoint of the urethra, and it's to be placed relatively loosely and certainly not under tension, so that the urine can still flow, but to provide additional support during episodes or triggers that may cause incontinence. So if you can see my finger on the screen and imagine that's a urethra, it's a bit longer than the average female urethra. And then this here is a mesh sling. It's a piece of mesh, and you can see hopefully the weave of that.
So you can see nicely that it matches your cupboard there.
Very much so. And we're aiming for it to sit along about the midpoint of the urethra, relatively loose, like I say, not too loose, obviously, but it's got to be able to provide support when there's tension or pressure on the urethra so that the urine doesn't escape. So in the context of urinary incontinence, it's mid-urethra, and they're actually called mid-urethral slings. And that's involved... The placement involves a small cut in the vagina, about 1 centimetre, that corresponds with the midpoint of the urethra, and then it's either passed across the vagina and comes out through the groin at the obturator foramen, or just above the pubic bones at the very bottom of the tummy, just in the hairline area. And 2 small cuts are made in the exit points, often to facilitate that exit. Now for prolapse, it's slightly different. The mesh there would sit in the vaginal wall. Now the older meshes that are no longer available for use can be were placed through a cut in the vaginal wall, so to sit between the vagina and the bladder, or the vagina and the bowel. Now, we don't use those anymore, but we still have some meshes available for use to perform prolapse surgery. Again, placing between the vagina and the bladder, or vagina and the bowel, but this is placed through abdominal surgery or keyhole surgery, and we have to separate the vagina and bladder, or vagina and bowel, and stitch the mesh along the vagina to fill in the gap between the two. And we use this type of mesh for that. So you can see that there's a sheet there, and then it separates to form a Y shape, with one part of the Y going down the front of the vagina and one down the back to provide the actual support. And then this tail part attaches to the sacrum to provide the overall tension and support to prevent the vagina completely prolapsing. So to answer your question,
it sort of lifts it all up, Matt.
Yeah, it lifts it all up, and so it's being placed for prolapse between the prolapsing organ, such as the bladder, and the vaginal wall.
Okay, great. So you did mention about some meshes that we no longer are allowed to use for the vaginal placement. So what are the current concerns around placement with mesh?
So some women have complained of quite significant complications with this that have led to severe pain, and that can be pain in the pelvis or vaginal area that's not provoked, or it can be pain particularly during sexual intercourse. Or perhaps more commonly even, women have complained that the mesh has become exposed through the scar or the incision through which it's been placed. So they can feel the mesh, or sometimes even their husbands and partners can feel the mesh during intercourse. So we call that mesh exposure, although the term mesh erosion has been commonly used in the past as well. So in that situation, the woman might be able to feel the fibres of the mesh, which are reasonably prickly, or it may be visible on clinical examination, and this one's blue. Some of them are white, as you may have seen, but they may be visible through those incisions and scar lines. That's probably more common with the bigger pieces of mesh that we used for prolapse and placed through the vaginal cuts. So for those ones that would look a bit like this is another one of my props. So obviously a slightly bigger piece of mesh, and that requires a bigger incision to place it. Yeah, so it's much wider and broader than the thin strip used for incontinence. So it needs a bigger cut to place it, and there's a much higher risk of pain and mesh exposure with these types, possibly as high as 10%.
It's quite high.
Whereas with the thinner mesh slings, it's probably only about 2%.
Okay.
In terms of pain, much higher with the transvaginal prolapse meshes. So again, 5% or upwards of women with that may complain of pain issues. Whereas the data seems to suggest that it's only in the region of about 1% of women for a mesh sling. Although there is some suggestion that those placed across the obturator bones, or the obturator foramen, and coming out through the groins, there is a rate of about 4 or 5% of them having groin pain too. But that can be avoided with the suprapubic slings. So they're the main concerns, issues with pain.
In terms of that,
and the risk of mesh exposure.
Okay, so in terms of that, because we hear a lot in the media about mesh, and we've heard a lot about the court cases in America, and there's been changes in Australia as well. So here in New Zealand, are we still allowed to use mesh for our female patients for different procedures? So
yes, so this type of mesh for what we call the transvaginal mesh for prolapse, that's no longer available in Australia or New Zealand because of the high complications and the fact that there's very little advantage compared to more simple surgeries that don't require the mesh. The mesh slings for urinary incontinence are still available, so that's these types with the thin strips that I was demonstrating before. And the abdominal or laparoscopic placed meshes, such as our little friend here, they're still available for use in Australia and New Zealand as well. The Australian Commission on Safety and Quality in Healthcare has produced a pathway for surgical management, and we can just show that now. So that's up there now, and what you can see with this is if the stress incontinence isn't responding to your simple conservative measures that you'd always try in the first instance, like physiotherapy and weight loss and other things, then you do have a number of options for treatment, one of which is the synthetic mesh midurethral sling. And that's actually in green because it's perceived to be one of the preferred options for this type of surgery. It only involves little cuts and is quite a short procedure, so it doesn't require a long anaesthetic, and therefore there's a very quick recovery from this, which is very attractive to a lot of women. Now might be a good time to talk about some of these other options, since we've got them up on the screen.
It's a great opportunity to talk about them.
So yeah, we also have...
Tell me more about the bulking agents then.
So a bulking agent, they've been around a while, and they involve injecting collagen into the urethra, usually at around the bladder neck sort of level. They are very, very minimally invasive. They're having a bit of a resurgence at the moment because a lot of women are concerned about the use of mesh and want to avoid bigger surgery. Unfortunately, the results aren't necessarily very good. Most would quote about a 50% success rate, but they are very, very low morbidity. So there's not a lot can go wrong with them, and there's very minimal risk associated with using them. Other procedures are commonly talked about include what's called the pubovaginal sling, and that requires some abdominal fascia to be used, or it might sometimes be called a rectus fascia sling. So it again places the sling under the urethra, but it requires a larger abdominal cut to do what's called harvesting the sling, and you require a reasonable length of rectus fascia, which does carry with it a risk of increased pain following the surgery, longer recovery, and even a risk of hernia because of the need for the tissue to repair itself. Sometimes as well, people are starting to do fascia lata harvesting. So that's fascia taken from the thigh to use that. That's relatively new. I don't have any personal experience of doing that, but I am aware of some surgeons in Australia and even New Zealand starting to do that. It does avoid the abdominal incision, but might lead to complications at the harvest site in the leg. Then there's this procedure called a colposuspension that again is performed through a larger abdominal incision, similar to what you might see for a caesarean section or old-fashioned hysterectomy. And sometimes it's done laparoscopically as well to reduce the risk of that incision. However, this basically involves placing sutures alongside the urethra, but in the actual vagina this time. And it's in a space called the retropubic space, or sometimes called the cave of Retzius, which is behind the pubic bones, but outside the peritoneal cavity. And then the vagina is lifted up to increase the support of the urethra. Again, it's a bigger operation and can predispose the woman to vaginal prolapse later on as well, because of how it alters the shape and dynamics of the vagina and the pelvic organs. So there are definitely alternatives to mesh. The midurethral sling, the colposuspension, and the fascial sling all have similar success rates. They're all, in the short term, quoted as having between 80 and 90% success to treat stress incontinence. They vary in terms of their immediate morbidity, things like bleeding, pain after the surgery, and their longer term risk profiles. So it really comes down to what the woman's preferences are in terms of recovery and what risks the woman's willing to tolerate. Then the bulking agents have much, much lower success, as I've said, but they have much, much lower morbidity. So again, that might be a trade-off that the woman is keen to consider and accept for her treatment.
Okay. So, because you've got this beautiful picture up for us, and thank you, this makes it quite clear that actually mesh is still considered a reasonable option for urinary incontinence, which I think is quite important for people to know, because I think a lot of the information that's out there does scare us away from using mesh and makes people very risk averse, understandably. So when people use the word mesh and they use the word sling, often they use it interchangeable, but it looks like from this that probably using the word sling and mesh really depends on what procedure they're talking about. So do you think they should be interchangeable, or what would you say on that, John?
Well, I think it's important that we're honest with our patients and that they understand exactly what they're agreeing to and what we're talking to them about. So, as you've pointed out, and as the chart illustrates, we've got two different types of sling. There are our synthetic mesh slings, and then there's our native tissue slings. So, my personal approach would be to refer to the mid-urethral sling as quite simply as a mesh sling, which, it seems to sum it up quite nicely and honestly for the patient.
I think that's probably my approach as well, to talk about the mid-urethral mesh sling versus a natural tissue or native tissue sling. So if I came to you and I had incontinence, urinary incontinence, definitely stress incontinence, as a middle-aged lady with having children, so it looks like I could still have mesh as an option, because a lot of people are now talking about not using mesh whatsoever. So in New Zealand, if you saw someone, in theory, they should still be able to offer you all of these options that you're demonstrating here.
Well, I think that's only the fair thing to do, is to make sure that we're able to offer, even if we can't necessarily do it ourselves, but these women should be aware of all the options. And if they prefer an option that we can't perform ourselves, then we are happy to refer to a surgeon who can. So it does require time to discuss this all, and provision of written information, and possibly even more than one appointment, so that the woman's had appropriate time to consider and discuss everything. But absolutely, they should be given every option. And we mustn't, of course, forget that surgery should only really be tried after non-surgical management has been discussed and considered.
Yes, of course, absolutely. I have said on many occasions I'm a huge fan of pelvic floor physios. I think they are amazing in what they can achieve. And yeah, absolutely. Physio should always be tried first, I think. Okay, great. I do see that the mini sling has a big red line to it now. Is that because it's no longer considered a viable option? That's
right. So they've used with the construction of this, they've used a traffic light style approach. So the green is for the preferred option. So based on the available evidence that was considered when these pathways were generated by the group that develops them, which I included gynecologists and urologists and physios and other individuals. So the green was the preferred option. Orange are other options available, but the red are things that are no longer available. So mini slings, not something I ever used myself. They were, if you like, a work in progress in terms of the evidence to support them. And they were deemed to not really have enough evidence to support their continued use. That doesn't necessarily mean they were bad. It just means that there wasn't as much evidence available that had been researched and published by the time this was produced.
Great. Okay. So if I, again, come to you as a patient and I need to have my stress incontinence dealt to, but I don't want to have any synthetic materials placed in me, how would you advise patients who come and they say, right, I don't want synthetics, I've heard horrible things about it, so I'm absolutely adamant I don't want to go down this green light pathway? What would you say would be the next viable options in terms of the risks and their benefits going forward?
Well, even if a woman comes with that thought process, I still think it's important to try and discuss and try and contextualize the information and include the synthetic meshes in the discussion. However, certainly my backup approach would be the pubovaginal or native tissue sling. I've got more experience with that recently than the copper suspension procedure. the copper suspension in particular is an operation that hasn't been performed in a large volume for quite a few years now.
Yeah.
It was previously the commonest operation for stress incontinence up until about 20 years ago, but it's not been performed a lot in that time. And way back then, there's a few articles from back then that do indicate quite high rates of pain and dyspareunia, painful intercourse, with the copper suspension procedure, possibly even higher than we're now seeing in relation to the mesh slings. So I've got a slight unease with the use of the copper suspension operation in particular. I've also got a slight unease about people falling back on old procedures that they haven't necessarily done for a long time, don't necessarily have recent experience of. So I do know that particularly a lot of urologists have continued doing quite large numbers of pubovaginal slings and rectus fascia slings over the past 20 years or so. So I would say, for me, that would be the better backup to a mesh sling. And plus it has similarities with the mesh sling in terms of its placement. So I think as a surgeon, that's something I'm a lot more comfortable with in that respect.
So I would agree with you on that as well, John. I think the copper suspension lost its way because it had such a high rate of complication, and so for it to be reinvented as something, I think it is really risky for patients, and I think it's something that they do need to ask their surgeon, what are your complication rates, right? Not what are the textbooks from the 1980s, but what are your complication rates like, because it does seem to have a lot of pain associated with it. And of course, pain is part of the problem that we're seeing with some of the transvaginal meshes for prolapse that were placed. So we don't want to replace one pain procedure with another pain.
Yeah, and people in the past, they weren't necessarily as good at reporting the negative aspects of this.
That's true.
Or any type of treatment. And that's one thing where the advocacy groups have probably made a very positive impact on medical practice, is forcing us to look at the negative side of the things that we do that we may not have done in the past.
Yeah, no, I agree. I think it's very important that patients do ask around these questions around what, as surgeon individuals, outcomes are, because we all have variable outcomes. We all have different skill sets. So, and again, it is, as you said, John, if you can't, as the surgeon involved, actually deliver that care for the patient and what they need, you should put your ego aside and send you on to someone else who could possibly deliver that. So I think that's a really important message for our patients out there in New Zealand.
And so certainly what we're seeing more, I mean, as we're chatting to each other now, and I think urologists and gynecologists are chatting to each other a lot more in their hospitals. We have, as I'm sure you do in Auckland, we have our own multidisciplinary teams that meet at least every month to discuss cases. So we'll have meetings with our physios, urologists, continence nurses and colorectal surgeons. So we collaborate a lot more, and this transfer of care becomes a lot easier, I think, in those respects, because the boundaries are broken down and it's much easier, as you say, to put the ego to one side. Yes,
and I think that's an important learning curve for all of us as we've gone through with this mesh, and to remember that mesh is not all bad, and that there's still some viable places to have it placed. So if I did have mesh placed, can I have that removed going forward?
You can, and we do unfortunately see this quite a lot. Some women are needing just small amounts of mesh removed. So if there's the most obvious example would be if there's a case of a mesh exposure, like I was talking about before. So there might be a small amount of mesh visible through the vagina, and that's amenable to just a small trimming, so that you can just trim the small area of mesh and then close over the edges of the wound again to cover that up. As with any continence surgery with the mesh slings, there is also the risk of difficulty weeing afterwards, so obstructed voiding, so division of the tapes. is another common thing that needs to be done. And sometimes just removal of a thin segment of the mesh just in that midline is necessary. I do think actually that's in some ways an advantage of the mesh sling, because very often the woman, or most often in fact, the woman who's had to have their sling revised to relieve some obstructed voiding, they still remain continent afterwards. So
good
and it's very easy. It's very, very easy to just cut out a small piece of this. I use these blue ones, so they're relatively easy to find, and much easier to do that and leave your patient continent afterwards than one of the other procedures, for example, such as the birch copper suspension. So they're two examples of where removal of mesh or revision of the mesh can be quite simple and straightforward. A lot of women do come back complaining of pain, and other things may be tried to relieve that, but ultimately you may need to remove it. In the past, I think there was a move to try and remove all of it. Lately, I think most people are sort of seeing that the risk-benefit ratio doesn't necessarily justify always trying to remove it all.
Yeah.
So if we go back to one of my other props, this one, for example, which is a transvaginal prolapse mesh, it's got these long arms, and they go through the sacrospinous ligament. It's quite deep in the pelvis, and it's quite close to lots of nerves and blood vessels, which can be one of the problems when you're putting it in, because you've got to avoid those important structures, but also taking it out can be fraught because of that. And there may not necessarily be much benefit to doing that. If the woman's pain is centered around this main body of the mesh, rather than related to the nerves that these arms might be near, then you're not necessarily going to achieve very much other than putting her at more risk by going to the added effort of removing that and increasing her risk of bleeding and injury in that process. So it's a tricky balance, and it has to be individualized for the patient. Unfortunately, it is often bigger surgery to remove these things than put it in. But fortunately, it's not that common. So as I've said, for the mesh slings, it's probably in the region of about 1% for the mesh incontinence slings. For the prolapse meshes, the transvaginal ones, it may be a bit higher, between 5 and 10% of them are having to undergo revision. The way they actually work is because these holes, I don't know how well you can see the hole in the mesh there.
No, you can see them, yeah.
The woman's tissue grows into that, and they become quite firmly fixed. And so you need to have an experienced and skilled surgeon doing it, and be mindful, obviously, of the nearby structures, such as the bladder, that might be injured during that surgery.
Okay, that's great. Thank you very much for your time today, John. I really appreciate that, and I'm sure that all our members of Continence New Zealand will appreciate that update and information about the mesh, particularly this slide. I think that was really useful to see with the traffic light examples. So that's great news. So thank you so much. Hopefully people will enjoy this, and I'm sure we'll be inviting you back for more of these. So thank you for your time.
Great, thank you. It's been a pleasure.